Good morning, everybody. So, because this is, still not, can't see the slides, apologies. You should now be able to see my slides, is that right? Okay. So, just some housekeeping, because this is virtual. We will be moving people into breakout rooms at that point in the agenda. Am I right in thinking the agenda is posted in the chat, which you should be able to open up on your Zoom screen? And the chat will then be usually on the right-hand side of the screen. The screen will look a bit odd at the moment because I'm sharing my slides, but it will go back to normal when I stop. So, this slide I'm showing is an example of the sorts of impacts that we have as an applied research collaboration over the time of the projects that we've been working on since 2019. So that's what the slide is for. So those of you who don't know me, I'm Mark Gabbay. I'm Professor of General Practice, University of Liverpool, and I'm Director of the ARC Northwest Coast. A bit of housekeeping. Please do keep your cameras on. It makes it much easier for people to feel that they're actually in a meeting when they can see their colleagues on the screens. If you want to speak, please raise your hand. You'll find that on the menu on the Zoom screen. There's also other things you can do if you want to applaud or put your thumbs up or look shocked, I think. Please be nice to us. We're doing our best. It's quite challenging for us to manage such a large group on Zoom and get people in and out of breakout rooms in a timely way. So please be patient as we do that when the time comes during the day. We'll be putting contact details in the chat so that if you want to contact us about anything, you can put something in the chat or email us and we'll get back to you as soon as we can. A lot of you will be wondering what's happened about the application we put in for ARC Phase 2 to start in April 2026. I'm afraid the outcome of that is still strictly embargoed by the Department of Health and Social Care. We are continuing to plan actively on the assumption that we will get full funding for ARC2, but I'm not allowed and I'm not in a position to give any information about where we're up to with the outcome of that, either locally or nationally. But as soon as I am able, or we are able to give that information, we will be producing communications on that, but we have to wait for the get-go from the Department of Health and Social Care. So going back to the slide, so what you can see on this slide is that we've been doing a whole variety of different ways that we can produce an impact as an applied research collaboration. That's what today's ARCFEST is about. How do we make a difference? How do we make an impact? What can we do? What can we learn from each other as to how we can better make impacts from our work? And the sorts of things you can see here is information we've given to parliamentary committees, individual trust projects on medical adherence, evaluating various primary care initiatives, how we work with councils on approaches to making the local economy work better. We've sponsored over 30 PhD studentships, around 100 internships and fellowships for our member organisations to help them learn research skills and undertake work. These are all things that we do, and through that work, working with our member organisations, we hope that we're giving sustainability to that impact, because those skills on how to do projects, how to lead projects, how to implement change in their organisation is supported by the ARC and hopefully will spread internally. That's why we focus so much on working with our member organisations rather than it being a passive relationship. It's a very active relationship. We've also been doing lots of work on dementia. Some of the work we've been doing is going global. And we like to think that we also support our implementation and our impact by the way that we work with the public, with practitioners alongside academics, so that we can make a real impact to how health and care is delivered both in the Northwest and more widely. So our priority for the rest of this ARC until the end of March is to work effectively with our member organisations, communities, public advisors, practitioners, voluntary community organisations, faith organisations, to upscale our impact. In ARC2, we will be expected and judged on making national impact. So it's really important that we start to get this right and start to drive that process in the expectation of starting ARC2 in the 1st of April. What we're going to look at in the breakout rooms is how we overcome hurdles to implementation and making an impact. And we're going to talk about solutions and think about case studies that we can use. The NHR, the government, is very keen to hear how we've made a difference, what differences we're making. So please take away from today the thoughts from what we discuss, what we talk about, take them back into your organisation and work with us on making a difference in this way. And the last slide I've got is that one of the things that you know that we try and do in the ARC is we want to look at how we're working, what's working better, what we could do improve, how we could do things differently. So if you scan this QR code on your phone, it will take you to a survey that we're running at the moment, asking our member organisations, our public advisors, those people that work with us, the volunteers, how we're doing, and how we've been doing, and how we could do better in the future. So please do take part in that survey. We do take notice of the information we get back. So I'm going to stop now and we'll move on in the agenda. So let me just get rid of my script. So I'd now like to invite our next speaker, which is Naheed Tahir, one of our public advisors, talking about why is making an impact so important in the context of the new NHS plan. So welcome, Naheed.
Thank you. Good morning, everyone. I am a patient representative at the British Medical Association, a role I find somewhat challenging and at times political. However, I am able to have opportunities to make an impact. At ARC North West Coast, we have a seldom heard forum, which I co-chair. We invite hard-to-reach groups and communities who often face multiple barriers affecting their engagement with health and social care. These can be challenging, and we offer a safe space for them to discuss the issues they may be experiencing. When the Chinese community came to their Seldom Heard Forum, an international student shared how she found the healthcare system difficult to navigate and never knew about GPs, something not all countries are as lucky to have. I then relayed this information at my next Medical Students Committee meeting. It was immediately taken on board and implemented that in the future, a welcome pack would be created to include a wellbeing section with information on gaining access to see a GP. This is valuable information that is needed for all students because those living in the UK who don't go to a local university and leave home for the first time also lack guidance on how to do this. A direct impact of our Seldom Heard Forum and the importance of having representatives. Being a public advisor has given me the chance to be a voice for not only my community, but for all communities. In July this year at BMA House in London, while attending a General Practice Committee meeting, I also had the opportunity to listen to Stephen Kinnock, the Minister of State at the Department of Health and Social Care. His speech was to let us know how brilliant the 10-year health plan is and how beneficial it was going to be for everyone, especially for GPs and us, the general public. The speech was not, I believe, a personally written speech, but more so one probably written by civil servants, as one might expect, and was apparent by the accompanying minions and advisors surrounding him and guiding his every word and answer to questions. It was a lot about neighbourhood providers being GP-led. He started off by acknowledging the many soon-to-be qualified doctors in August, hoping to serve local communities. Of course, with it being a GP committee meeting, he also thanked those GPs present for being so resilient in such challenging times, which is not apparent to the majority of the general public because of so much negative media. It really is exhausting. I understand it is difficult to see a GP, but they really are overwhelmed with work. I can say this because, as many of you know, my daughter is a GP, so I see and experience it firsthand, as well as I'm sure so does Mark Gabbay, our director of ARC North West Coast, and a GP and researcher himself. So getting back to Stephen Kinnock. He wanted a shared commitment and collaboration with all organisations to reform the NHS, to deliver impact and bring easy to access, high quality, continuous care to the neighbourhood health service with single and multi-neighbourhood contracts. I wonder how. Bringing back the family doctor while embracing technology. I wonder how. There would be a shift in funding from hospital to communities. I wonder how. He acknowledged that the most deprived areas actually received the least funding, and this was going to change. I wonder how. Resources would be targeted where it was needed the most. I really wonder how. He mentioned top-down systems not working and would start with the bottom up. Now we really are left wondering how. He was going to overhaul the broken NHS system and hit the ground running. He promised that under a Labour government, the NHS would always be free at the point of use. Politics, hey? There was no specific mention of research from him, as they're hand-picked questions and he had a script for answers, so the jigsaw pieces are still missing. However, there is evidence that the 3 key areas that can support the 10-year health plan have already been researched, are making an impact, and hopefully will continue to be researched. Number 1, hospital to community. Hospital wards and virtual wards. What works? Number 2, analog to digital. Artificial intelligence and interventions that work. Number 3, sickness to prevention. Is the NHS health check improving population health? These can be found under evidence on the NIHR website. I'll put a link in the chat. So this is where we come in and continue to make an impact to ensure research findings make a difference to service provision. We need to highlight the importance of existing findings being translated into something meaningful to improve people's lives. We need to support and engage with academics and research. We need to continue with the applied research collaboration with evidence-based research. We need to put that evidence into practice. We need evidence-based and researched toolkits which we can help contribute to and develop. This can be done in collaboration with public advisors who have lived experience on the ground, those patients, those carers, and those experts by experience. This is impact. Thank you.
Thanks very much, Naheed. So I now invite Selina Wallis, who's going to talk to us with, as the first of our 3 examples. We're going to start with Selina Wallis, then Clarissa Giebel, and then Dr. Nwosu. So over to you, Selina.
Thank you, Mark. I'm just trying to share my screen, but I'm having problems with my... I'm not sure whether...
with Dorcas, aren't you? I think you're doing it as a 2-hander.
Yeah, so Ruth, if you could share the PowerPoint. Sorry, I'm having problems with my screen, not wanting to share. Thank you, Ruth. Fantastic. So good morning, everyone. I'm the ARC North West Coast Public Involvement Manager, and just want to thank Naheed for her powerful talk about impact. I'll probably be covering a couple of the things that Naheed's already talked about. So if you want to go to the next slide, Ruth. Fantastic, thank you. So through the work that we have been doing around public involvement over the last, well, I was going to say 5, but actually 7 years with this ARC, we have accomplished a huge amount. The most important thing is that we have built trusting relationships with all our over 100 public advisors. And we've learned so much about how we can best involve the public and communities in applied health research. Naheed mentioned the Seldom Heard Forum. We've held 10 themed online forums involving hundreds of ARC staff, researchers, public advisors, commissioners, charities, members of the public, including several seldom heard communities with huge impact, which we will be producing information about in the near future. Through these projects and also some of our other work, including having public advisors as research co-theme leads, we know that involvement can result in positive, meaningful changes across multiple dimensions. That's to projects, to research, to individuals, which includes both the members of the public that are being involved in the research and also researchers themselves, and also to policies and structurally. But we also know that working in an area of high deprivation and considering the huge global influences on mental health, we need to recognise that high numbers of people are living with multiple adverse childhood experiences and current huge pressures, maybe financially or through things like racism and food insecurity. So we need to be mindful in all our activities to consider the effects of trauma. I'd like to introduce Dorcas, one of our long-term experienced public advisors, who's also one of the current public advisor co-leads in our HACL research theme, who is doing cross-ARC and national work around domestic violence. She was an experienced midwife and is used to supporting women and families over the most important transitions into bringing a new baby into the world, and is a long-term campaigner against the harms of female genital mutilation. If you can put the next slide up, please, Ruth, and Dorcas, if you'd like to.
Thank you so much, Selina, for that introduction. That's great. And thanks everyone for joining us today, really. I have got only one slide, and I've got 2 minutes to speak to convince you researchers, professionals, that you have to be more careful when you speak to a group about sensitive issues, which have caused trauma. And Selina has mentioned some now, like domestic violence and mental health is one, which is a taboo within some community, and also female genital mutilation. As highlighted on just look at the slide that you have got there. There are key aspects you have to consider from understanding trauma to communication and language. So when you're going to do your research, really, you need to know the group you are going to. And you need to use your public advisors as well to support you. When you carry out practice about sensitive subjects, such as domestic violence and mental health, just to mention a few, you have to ensure that you are aware of the group you want to consult and what they have been through, because you don't want them to have a flashback. Especially domestic violence is so sensitive, and we don't call them victim now, we call them survivor. For example, when I was going to write my thesis on my master's, I needed 3 groups of women from female genital mutilation practicing countries. And one group, they don't speak English. And what will I do? If I want to talk to them, I know we might be talking about no finance, no resource, but I didn't have money to give them. But I worked with a link worker that I've worked with at the Liverpool Women's to gather the women together for me in the local community. And I went to the local community to talk to them, to tell them what I wanted them to do for me. I used my interpreter to talk to this woman. So I had an interpreter which explained everything. Female circumcision is associated with pain. And the first pain is the day that it's done. And the second pain is when the marriage has to be consumed. So the night of the wedding. And the last pain is the delivery of the baby. I didn't want them to have flashback again to say, here comes Dorcas. We know what said the woman come to talk to us about FGM. So I have to be sensitive. I'm just trying to say what we have to do, you know, as when you want to go to group. Sometimes your group might be with learning difficulties. You have to understand you're going to them. They might be hard hearing. You have to make sure you talk to them where there's look, you know, or where somebody can sign language for you. So as Selina has just said as well, seldom heard you have to speak to them. You see, when you go to us and you come to us, we want you to know that you're empowering us as well as we're empowering you. And that is important. I have so many examples which have led to change in practice, but time does not allow me to cover, because I used to run a lot of lunchtime with old people. And for example, we're talking of prostate cancer. They didn't want to know. So the drama group brought 2 eggs, 2 eggs to show them how to look for it. And that had an impact. Although they laugh about it, but they understand what they had to do. So it's about trying to find out what you can do. But can I please here today to all researchers and professionals on the platform, endeavor to use the right language to communicate with the public. That's the most important thing. If you need a leaflet to translate, you don't have to translate so many. Just find out which language is common, and you can do that. You want to get people to be included, to be inclusive as well. How will you find out about inequality if you don't do that? How do you know what we wanted? Your group may have that learning difficulties, so you need to do leaflet that they can see and read. We are not hard to reach, are we? You just need to reach us. If you need more information, you can get me via ARC Northwest Coast, and I'm always willing to help. I'm always willing to gather people together to listen to you. That's my plea today. Thank you for listening to me. Thank you.
Thank you, Dorcas. Ruth, if you can move to the last slide, please. If you'll see on this slide some quotes from our Seldom Heard forums, either from presenters or people that have attended the forum. And I just want to make sure that as you read them, you think a bit about how impact is not just about reports and about papers. It's about whether the people that we work with feel safer, more respected, and more able to act after working with us. If the process harms them, then the outcomes don't count. We need to budget and plan for briefing people, for debriefing, for continuity and timely payments, so involvement does not cost people more than it gives them. And just a couple of reflections for the room. Can you consider where a member of the public might feel overwhelmed or alone when working with you or your project? And what will you change this month to reduce that burden? How will you show communities the impact of projects that they've worked on with you, and what changed because they spoke up? Thank you.
Okay, that's it. Thank you, Selina.
Okay, so Clarissa, Dr. Clarissa Giebel.
Yes, hello everyone. Bear with me as I'm going to share my slides. Right, share. Sean Cunningham, can you tell me whether you see the presenter slide or the full screen?
I can see the full screen.
Super. Right. Thank you. So my name is Clarissa Giebel. If you don't know me, I'm a senior research fellow within the HACAL theme, and I'm leading the older adult sub-theme in that. And I very briefly will show you an overview of how we started to gamify dementia education in the past 2.5 years, really. So it all started with the Dementia Inequalities game, which some of you might have seen by now at ARCFEST or at different events. This is loosely based on the format of Snakes and Ladders, because we want to educate anyone who doesn't know enough about dementia, and that could be the general public, that could be care home staff, that can be GPs sometimes, that could be Merseyside Police Force, anyone that comes into contact with people living with dementia and the unpaid carers about what is dementia, but also primarily what are some of the barriers and sometimes facilitators that people with the condition, their family members, can experience when trying to access a diagnosis and when trying to access care. So this has been launched in September 2023, together with the Lewy Body Society. It is the very first actual physical board game about dementia, and we've sold just under 200 copies now, and we're launching it in different countries. We're working with 12 UK universities so far, but the reach is growing, to embed it in undergraduate teaching of allied health professional students, nursing, psychology, etc. So we've done an evaluation already last year with over 300 students at the University of Liverpool, so orthotics, physiotherapy, nursing, psychology, etc. And we found that playing this game, which lasts a maximum of 1 hour in little groups, can significantly impact your knowledge about dementia and your knowledge about the associated inequalities. So when we talk about inequalities, that could be, for example, if you might have young onset dementia and your GP doesn't even recognize that you might experience symptoms of young onset dementia, because they might think only older people get dementia. So the game features all of these inequalities to teach and to educate. And we're now also currently hosting workshops with care home staff. So you see some of our members, one of our DEMCOM fellows in there as well. So we actively go out to care homes across the Northwest, and we're working together with the NIHR Enrich Care Home Network up in Scotland. So we've got research officers from the NIHR Enrich going out to different care homes in Scotland at the moment, because we want to see the impact of a 1 hour game session in care homes on staff knowledge. And so far, the data we have looks promising, but we obviously collect more data. And if any of you are working in a care home or are managing a care home and want us to come out to you, please let us know. So this has been happening since 2023. There's what we now call adult game, because it is meant to be for people aged 18 and above. But in our field of work, we increasingly come across younger carers, people that are not just 18, but especially with young onset dementia, children or teenagers who are caring for someone with dementia. But also we know that there is a lot of stigma still in society, and we felt as a team, as a group, that could we do something that tries to tackle this stigma and this lack of awareness in community and society from a really young age on. So we got some funding from University of Liverpool and the Public Engagement Fund to launch a second game. And again, this is the only board game available for children on dementia to date. So we launched this game last week, Friday. It's called the Dementia Explorer game. You see Jackie Cannon, who is the CEO of the Lewy Body Society, as well on this photo, proudly holding one of the games. Again, it's available via that charity, with all income going to charity or further outreach work for people living with dementia. And we changed it up a little bit this time. It's not solely looking at inequalities. What it does, having consulted with a lot of primary schools and teachers and people living with dementia and carers, is it breaks down the knowledge about dementia into 4 key sections. So children wanted to know much more about the risk factors, about the diagnosis, but also about what is it like to live well with dementia, and what could I do to support someone with dementia, because many of the kids might know a granddad, a grandma, or even a parent or an auntie who has dementia. So I'm not showing you the board game as such, but please get in touch with us. I'm not showing it to you because we're running out of time, but what I wanted to mention on my last slide, because as we're talking about impact, this gamification of dementia will feed into an impact case study that people are pulling together within our ARC, but also we're putting one together for the REF 2029, an academic case study. So with this game now launched, we are looking for primary schools and youth clubs to go out and do the same that we're doing with the adult version of the game. We want to host these game workshops for children aged between 7 and 11, and to see what's the impact of the game on their knowledge. And I'm going to stop here because I think I'm running out of time. Let me stop sharing.
Thank you very much, Clarissa. That's great. So hope people don't mind if we move straight on because of time, because we started late. Dr. Amara Nwosu, it's over to you.
Thank you very much. Can you see my presentation?
We can, yes. Yeah.
Fantastic. Okay, so my name is Amara Nwosu. I'm a senior clinical lecturer in palliative care at Lancaster Medical School, and I am an honorary consultant in palliative care at the Royal Liverpool University Hospital and research lead for Marie Curie Northwest. It's fantastic to have the opportunity to be here today at ARCFEST to tell you about our work that we've done to improve research activity in hospices through the Northwest Coast area using journal clubs. So the big idea that we have is a simple idea. It's that we want to improve research skills in palliative care staff by implementing a multidisciplinary journal club in initially one hospice, but this has now been rolled out to lots of different palliative care settings, not just hospices, across the Northwest. And journal clubs, historically, many people on the call may have been involved in journal clubs, which is great. But if you haven't, it just describes a collection of people that will usually meet to discuss a research article of interest to clinical practice or some area of your academic or clinical interest. And it's a forum to discuss research. It can, the evidence shows that journal clubs, particularly those on a regular basis, can improve learning for individuals and groups, but also can improve the research skills of culture for a group or organizations. They're often used in medical education, for example. Now, when you're looking at hospices and palliative care settings, there can be some challenges to trying to incorporate the learning of journal club activity in these places. One reason is that it can be intimidating because of the knowledge and skill that you have to do the interpretive analysis of it, because many of the staff may not have the academic. Many hospices have a low level of research activity because they often exist outside NHS and university structures, meaning that there isn't that culture of research and innovation in those areas. And often hospices sit outside the regulatory framework that you have with research governance and sponsorship that you get with the NHS and university. And also, if you have independent hospices where staff have got contracts directly with those organizations, they may not have the wider access to academic resources that we can sometimes take for granted if we have NHS and university contracts. So just being able to access materials can be more challenging. So in 2019, I had been at the research lead of Marie Curie Hospice Liverpool for just over a year, and I was keen to redevelop the existing journal club with a new model. In this model, I wanted it to move more from being centered on the medical staff to being multidisciplinary. So this is including all areas of the hospice. It's not just the medics and the nurses, but the housekeeping staff, the catering staff, the volunteers, the fundraising. And for this, we wanted it to be clinically relevant. So we asked 3 questions from each paper that was being presented. Is what are the main findings? How can this or should it change our practice that we do? And that could be just in the way that we talk to other people or the way that we present information. And then what are the unanswered research questions that we have that we can now go away to try to find the answers to improve the care that we deliver? In 2019, here's an example of one of our early journal clubs. The journal clubs would meet face-to-face every 2 weeks in person in the hospice. And this is an example of the type of attendance that we had for some of the journal clubs where literally every department in the hospice was represented. Unfortunately, in 2020, COVID-19 changed a lot of things, but what we did was to adapt to develop a hybrid approach. So you can see in the background there that there's a Teams link where people who couldn't be in the building also participated. But through this, we also launched the Journal Club across the Northwest. So other hospitals and hospices in the region could now join, which they did. We then presented it at a national conference at Hospice UK, and we had such positive feedback that we were contacted by many organizations across the country asking to join our journal club. So rather than do that, we developed a toolkit to help other organizations set up their own journal club. But this toolkit just gave lots of kind of simple advice, but also just provides the guide of how to actually practically do it. We then got funding through a competitive grant scheme from Marie Curie to actually evaluate this toolkit, which we did in the Lake District, in St. Mary's Hospice in Ulverston. We did this at the start of this year, finishing the data collection in around April, May time. And over 6 months, we developed the toolkit, set it up for them, and the staff rolled it out themselves and delivered the sessions themselves. And they did an incredible job. They did 6 sessions, which in total involved 42 staff across the whole of the hospice. There was 100% satisfaction from the analysis that we did. We did a questionnaire, and then we also did face interviews with some staff. And what we found was several case examples of improved morale and culture of the organization, with an increasement of research activity and quality improvement. And we also had examples of collaborative links that existed between Lancaster University and Liverpool University that didn't exist before, so they came out of this project. So in summary, our toolkit has improved research culture and engagement in hospices, initially in Marie Curie Hospice Liverpool, but then through several organisations across the Northwest and Merseyside region, now expanding into the Lake District. We will present our findings in an afternoon session at Hospice UK in 2025, which will take place in Liverpool in November in the M&S Bank Arena. And it has been adopted formally by Marie Curie, and there'll be a standalone web page to officially launch an online version of the toolkit for free for organisations on a national basis in December. We are also in the process of transferring the toolkit to other settings outside palliative care. So I'm developing it for Lancaster Medical School to provide medical students with research skills, and also Liverpool John Moores University to help research skills of postgraduate research staff and students. I want to acknowledge all of the partners that have been involved with the Journal Club. So these are all the different organisations that have had an active role in it. And I also want to give thanks to Sarah Stanley, Tom Steele, and Desi, who have been a key part of the Journal Club. So thank you very much.
Thank you, Amara. Okay, so keeping moving, as I'm expected to do. Thanks, that's great set of presentations from you all. We're now going to move on to Daniel Holland, who's going to talk about inappropriate adoption of inspiratory muscle training in acute chronic bronchitis. This is a really interesting project because we don't always do research that shows we should be doing something new. Sometimes we do research to show we shouldn't be doing something. So it's great to have your presentation to show this other side of the coin. Over to you, Dan.
Thank you, Mark. So, hi everyone, my name's Dan Holland, a physiotherapist at Blackpool Teaching Hospitals, and I'm just going to try and get my slides up. I am typically a user of Teams, so down
on the bottom.
Hang on.
If you look at the bottom, there's a green thing. If you move your cursor to the bottom, you see a green thing that says share. And then just click on the screen and click share.
No problem.
You might want to move your microphone down a bit as well. That's it. Got it?
I believe so, yes. Just
yeah, we can see that.
Let me know.
Yeah, there we go.
Are we all there? Wonderful. So my project with some of my clinical colleagues at the hospital in the physiotherapy and occupational therapy department investigated the use of inspiratory muscle strength training in COPD and how completing a RACES project influenced our practice. So here we go. So in terms of the idea, our organisation had recently introduced inspiratory muscle strength training to practice in critical care. We found that Well, in fact, let me just briefly talk about inspiratory muscle strength training. So it's essentially a method to apply resistance to a human during their in-breath. And that resistance is thought to have an adaptive response on the inspiratory muscles, i.e. the diaphragm. And what we found was that critically unwell people on prolonged ventilation had several issues related to their respiratory muscle strength and their inspiratory muscle strength, so that we devised a quality improvement project to essentially try to help with that. And what we found was that it could reduce length of stay in critical care, hospital length of stay, improve dyspnea and quality of life scores. So after we'd successfully implemented this to our critical care setting, we then had these devices and this method of using the intervention and wanted to explore using it more within other teams and within our department and within the acute setting. And that is when we found that there was a large evidence base centered around the use of inspiratory muscle strength training in COPD. So knowing that, we have this idea, now what? So of course, we'd recently done a quality improvement project in critical care, and we considered the use of that quality improvement framework to try and introduce this inspiratory muscle strength training technology to other environments, particularly like our respiratory wards and our respiratory high care, which is called the medically enhanced care unit. The issue that we came up with was, would this actually work on the population that we are looking after? Because it's a subgroup of those with COPD that are acutely exacerbated or in a subacute phase post-exacerbation. And so that is when we decided to review the evidence, and we began to collaborate with the RACES team and embark on a project to appraise the evidence relating to our idea. So in terms of timeline, we identified a Cochrane review within the past 3 years relevant to our idea. And the review looked at inspiratory muscle strength training alongside the use of pulmonary rehab in those suffering with COPD. And the article itself was able to identify low to moderate quality evidence of its effectiveness in this population. However, what the review couldn't explain is what became very important to us, is that there were several examples within it of excluding participants because of an exacerbation, or excluding data from their studies because of recent exacerbation. And that removed it from data collection and therefore the review. And what we then found is that that exclusion actually significantly limited the external validity of the findings for the target population. And then importantly, that left us with this gap in evidence suggesting that the actual feasibility of us introducing this new intervention to the subgroup that we were looking into might actually be questionable from a safety aspect. And so following on from the completion of the project, our team opted to create an academic abstract and the subsequent poster, which discussed the findings and kind of the unveiling of this evidence gap within acute exacerbations of COPD, as we were unable to really find any evidence of it. The poster was presented at a national conference for the Association of Chartered Physiotherapists in Respiratory Care in April this year in Edinburgh. And our practice was ultimately influenced in, despite having evidence of it working, the evidence couldn't be applied at that time to our acutely exacerbated hospitalized group because we weren't able to demonstrate that it would be a safe and feasible idea. And this is just a quick visual of the poster. I'm not expecting anyone to read it, but this was just a poster from the conference, and it focused a little bit more on those themes and those evidence gaps. So in terms of what's next, so since we published this article spring 2025, our clinical team at Blackpool Victoria Hospital has collaborated on 2 further RACES projects, which are exploring more aspects of respiratory and physiotherapy intervention within some of the services that we run. We are then having a workshop across our acute therapies department, which is due in March 2026, which we aim to have 4 to 5 subgroups all planning to conduct RACES project. And we have quite a good amount of people already interested there. So that's coming along nicely. And because of how this influenced our practice and made us change direction, we then presented the importance of evidence appraisal and discussed RACES projects and their influence to our wider therapy department in July 2025 this year to over 150 invited colleagues. And now our team is currently preparing a scoping review to delve further into these evidence gaps that we've identified during the RACES project as well. So in summary, our team was able to develop skills in research appraisal, something that to some of the members of the group, it was quite a new thing. Our wider department has now become more involved in research. And of course, we may go from having had done one of these projects to potentially 8 or 9 of these projects within a 12-month period, or close to 12 months anyway, which would be absolutely fantastic. And our department is understanding more about criticality when it comes to evidence-based. Of course, we are looking to further explore the evidence gaps that were unveiled within this project and hopefully add to the body of research in the future. And then we have several interested parties across our department that have learned of this project that now want to conduct more projects. And we're getting into quite a good flow of things there. So it's really sort of set the ball rolling for this department and the wider acute therapies department at this hospital, who were not massively involved in any of these projects prior to this. And that is my presentation. Thank you very much.
Great, thank you very much. It's really interesting. So moving on, if that's okay. People, please put questions in the chat. I hope you've all found the chat on the right-hand side. There's a lot of discussion and points being put in there. So thanks very much, Dan. I'm going to now move us on to Jim from what's called the secure data environment, which is where we hold a lot of the NHS data. And Jim's going to talk about enabling data-driven improvements in managing population health. So hopefully over to you, Jim. Is Jim here?
Jim, you're there, but we can't seem to hear you.
Or see you.
I can definitely see Jim, but I can't hear him.
Yeah, I can see him too.
All right.
It's the change of system from Teams to Zoom. I imagine it's got confused with the sound input output.
Can you hear me?
Oh yeah,
Can hear and see you now, Jim. Yeah,
you can see and hear me. Thanks for filling, Sarah. You're absolutely right. The difference between Teams and Zoom, you'd imagine, is nuanced, but not for me.
You found the share button.
Yeah. So yeah. Okay. Good morning, everyone. Sorry. Right. Can you see? Am I sharing my screen? Okay. Can you see that?
I can't. I can just see you still, Jim.
Oh.
You need to tap the share screen on the when you've clicked which screen you want. It's going to work now, I think. Yeah. There you go. On you go, Jim.
Thank you very much. Good morning, everyone. I'm going to talk about population health management across Cheshire and Merseyside, and also about the Northwest Secure Data Environment and the impact that ARC has had on these two areas of work. I'm joined by my colleague Andrea Asprey, who's on the call today. She's the program director for the Data into Action program for Cheshire Mersey. Unfortunately, I was also going to be joined by Helen Duckworth, who's works for Arden and Gem CSU and is the technical and data lead for the Northwest Secure Data Environment, but she is she's called away to Northwest Secure Data Environment National Meeting in Leeds. So unfortunately, that's she's not able to join us today, but I'll cover her slides. So just if I can begin just to sort of explain where what we have done in Cheshire Merseyside in order to embed the research work and the outputs from the ARC into our governance to ensure that it has maximum impact. So we have within the University of Liverpool, we have the Civic Health Innovation Labs called CHILL, and we've aligned that the governance of that with a program within Cheshire Merseyside Integrated Care Board, the ICB, which is called the Data into Action program, which is largely around population health, but also covers most of the work around the use of the Cheshire Merseyside data assets. And because we're able to align the governance, it means we've been able to maximise the impact of ARC into the work that we do, and hopefully that diagram explains some of that. Just to give you some sense of what that means, and we'll cover some of this through the presentation today. There are a number of projects which are now not just if you like on the edge of the work that we do, but very much embedded into our work, and it includes the work that Andrea will present on today on complex households. It includes we also have a slide on how the unique property reference number has been flowed into data sets to improve data richness and insights. We'll talk a bit about how some of the ARC projects are now featuring as pilot projects into the Northwest SDE, and how we've got ARC involved both in the technical and in the overall leadership of the Northwest Secure Data Environment Programme. So this is extensive work, and we can only really touch the edges today, but hopefully you'll get some sense of the kind of impact that we're making. So we'll pick some of these out today. So I'll pass over to Andrea, who hopefully can be seen and heard.
Hopefully you can hear me, Jim.
You've had time to practice. So so I'll pass over to you, Andrea, and you can take us through the next few slides.
Brilliant.
Just to reassure you, we can see and hear you, Andrea.
Excellent. Thank you, Mark. Morning, everybody. I'm Andrea Asprey, the Data into Action Programme Director across C&M. And I just wanted to give this, what I think is a really great case study of the kind of power of the joined up approach between academia and health in terms of understanding our population to better effect. So if we just move on, please, Jim, to the next one. And I'll just give a little bit of background in and around the complex households piece. Yep, there we go. That's it. Great. Thank you, Jim. So in essence, really, the University of Liverpool Civic Health Innovation Lab has led some really groundbreaking insights into our complex households population. And this has been really in train for a number of years. We've known that there are parts of the population who, for a number of different reasons, interact and utilise health and social care services in quite a different way. And when we started off on this journey, I think that was a lot of the thinking was really about some of those people who, you know, were quite at the acute end, experiencing really chaotic and quite challenged lifestyles, perhaps had, you know, alcohol or drugs and substance misuse, perhaps homeless, and had quite a, you know, a challenged set of conditions which made their interaction with health services a lot more challenging for them personally. But over time, that thinking has really developed and matured, and we've really wanted to start thinking about a much more holistic sort of life course approach to individuals within complex households, because we know that obviously a lot of sort of childhood trauma, a lot of circumstances in younger life can have a really big impact on the way in which people go on to develop conditions, or go on to achieve or struggle to achieve in life. So we wanted to really take that into a household context, because we knew that if we wanted to get upstream of that was going to be really important. And so the University of Liverpool's insight in this space has really sort of helped challenge a lot of our thinking in the NHS about how we understand these households and how we can better support them. So the work has been really instrumental. We've got a new methodology, which is our complex household methodology, and we've really been putting this into practice over the course of the last 18 months or so, really, in practical terms. So we've taken the original insight, the original methodology, and created a new data dashboard. So we're not just doing this in a theoretical sense, it's very practically applicable to us now in Cheshire and Merseyside. And we've been doing a huge amount of work to roll this out across a range of different organisations, and particularly as well with our colleagues in general practice. So lots of work being done via our Population Health Management Academy to bring this to life. So if we just move on, please, Jim. So this is just these specific definition that we've got around complex households, and we are always thinking about whether or not this definition is exactly as we would want to see it. And there's still lots of work happening around research in this space to really be thinking about other component parts, like what is the spectrum of complexity in complex households. So we don't really see this as a static thing, but this very much guides our thinking at the moment, which is not only thinking about the physical, but also the mental health conditions in households for both adults and children, and the range of risk factors that these households can be experiencing. Plus also how their interaction with health and social care. So if they're in that upper quintile of utilisation, we would also see that as a characteristic of these households. So that's been very helpful. So if we move on, please, Jim. So that's the definition that as I say, that we're using currently. So we're absolutely clear and consistent on what that looks like across all of the 9 places in Cheshire and Merseyside. And what's been really powerful from this is that we know that, obviously in sort of more deprived and more urban areas, we are seeing a greater density of these households, and that's depicted on the map that you can see there. But it's also been really useful in showing that actually all of our places in Cheshire and Merseyside do have these families. You can also experience them in sort of poorer, rural areas. So the academic insight has really been challenging some of our, preconceptions around what complex households may look like and where they exist. And you can see there the sort of the key message on this slide being that only 8% of families of complex households are accounting for 34% of health and social care costs, which for the ICB is over 300 million a year. So it's an extremely important agenda for us in terms of an outcomes perspective, in terms of a system sustainability perspective, and that's why we're really keen to do a lot of this work and take it into practice. So lots of insight and papers that have been published there. But as I say, this is not a static piece. It is very much continuing to build on the insight to shape our thinking. So this is a visual of what the complex households dashboard looks like, and this is live across all of our 9 places now. And as I say, we've been doing a number of, say, drop-in sessions with GP practices, with teams across, say, Merseycare or community mental health providers to raise awareness of what this additional insight can bring to a health and care system. So it gives a nice summary of what the population looks like and where they are, and also tells us the kind of population need groups or patient need groups that these people are residing in. It's been really helpful for us to see that actually there's quite high numbers of people who are actually low need in terms of their profile of medical profile. So we know that there is an opportunity to intervene, and it's been helpful for us to have these conversations with the likes of our colleagues, say PCNs. We've got social prescribers established in PCNs, in primary care networks, but also in partnership with our voluntary and community faith social enterprise sector. And we've got a session booked for October to start rolling this out across the voluntary sector as well. So this has been live for almost a year, and we have specific contractual levers in a couple of our places to embed this. So moving on. And then this is just a second page of what the complex household tools offers us, because we can start to delve into a particular neighbourhood or PCN or particular place across Cheshire and Merseyside, and we can add in some additional searches, characteristics of those households. The insight from the university has been really key for us in really adding on additional risk factors or characteristics of the population, so we can take this kind of dashboard and make sure that we apply it to best effect. And a good example there is that the evidence has shown that lone parent households are a particular risk factor, and that's something we can search for on this tool. And so, you know, we can actually target some of our interventions to those households, because we are, you know, there's justification there that actually their outcomes are likely to be poorer than households where you've got two parents. So it's been really useful for us. You can see actually we can even give an indicative cost of a household over the past 12 months. And that helps us sort of in terms of thinking, well, actually, if it's really complex, it might be more of a holistic medical intervention review that's required. If those costs are lower down, maybe some of the non-medical interventions are appropriate. But we discuss those in quite some detail in our data into action multi-professional steering group, which again is also supported by the Civic Health Innovation Lab. So just moving on, and these are some examples of the work we've been doing to date across Cheshire and Merseyside places. We will continue to reach out and try and, you know, have greater consistency, but we're still, you know, in relatively early days. I would suggest this needs to be a 5-10 year plan about how we support complex households. But it's been really reassuring to see that there's been a lot of interest over the past few months by utilising local contractual levers, but also in the national primary care contract this year, there was also an element to ask for PCNs to consider how to identify patients who would benefit from continuity of care. So we rolled out the complex households dashboard with that particular contractual lever in mind, and had over 100 practice staff join sessions in July who were really interested in knowing more about how they could do that. So over the course of, you know, the next 12 to 18 months, we would expect this list of different interventions to significantly expand in terms of scale and pace. So just moving on, which I think is my last slide, we know that obviously the broader determinant issues for complex households are absolutely significant, and that actually the prevalence of respiratory illness in these households is significantly higher than the general population. So it's great to see that there's further work that's being done to assess that interaction between home environment and health and wellbeing outcomes. So some great work that's happening between the ARC and Groundswell, Sarah Rogers and Ollie Butters working with NHS England, and they have a new monthly flow of people in households where they can review the, you know, tracking changes to health if their access to healthy facilities improves, and the ICB are keen to support and facilitate a new data provision process for community and local government data, and this is being progressed by the Liverpool Combined Authority. So lots of opportunity for us to further enhance our understanding of these households and see how particular interventions can make a demonstrable difference to outcomes. So a really exciting agenda, and one that has been massively enabled by the academic insight. So I will hand back over to you, Jim.
Thanks very much. And conscious of time marks, I won't dwell on the last couple of slides too much, but I just wanted to talk about the impact on the Northwest secure data environment, which has been established as a network of data environments across England. There's 11. There's due to be 7 in the end. Regional environments that will support all academic and NHS and indeed commercial research. So just to say what for the establishment within the Northwest, where we've had very specific expertise and leadership added. The diagram is there not so much to be read, but to be admired, I suppose. But on the right hand side is the secure data environment within which the data will be stored, and over on the very right hand side is the researcher, and on the left hand side are the set of data stores that need to be federated and brought together in order to be part of a secure data environment for any specific research project. And from the ARC, we've had academic leadership across that whole area, including bringing in stakeholder bodies, bringing the ARC Northwest Coast closer to this work and influencing the development of it. And we've had technical expertise in how the data will be federated, so it can stay in source but be federated into a secure data environment. And also we've had a number of projects, which I'll just note on the next slide, that have where for Cheshire Merseyside it's dominated the number of projects moving into the Northwest SDE. And I think it's a result of both the partnership and also the way that we've established our governance within Cheshire Merseyside. So the three projects that are first through the gate, if you like, to test the system are the program formerly called System P, which is a population health set of population health projects. The Restore project, as noted there, and also the Groundswell project under Sarah that's been mentioned before. So just in summary then, I'll just go back to my opening comments. What we see here is significant impact of the Northwest Coast into a health and care system in terms of both supporting and leading and providing technical expertise and academic rigor into how a health and care system and a health and care learning system can appropriately develop and be sustained. So I'll leave it there, Mark.
Thank you very much. Okay, so hopefully that's given you a flavour, colleagues, of the sorts of the breadth and depth of things we're doing for impact. We're now going to move into our group discussion rooms, and we'll try and catch up time as we go. In those rooms, we're going to discuss what hurdles exist when we're trying to implement findings, and what approaches you've found that work best to support the delivery of research findings into practice. What else can we do to help the delivery of these findings to make a difference to people providing services and receiving services and wider populations? So you'll find yourself being moved into groups now. Hi everyone, welcome back. Hope you found that useful. I think everybody's feeding back in now. Is that right, Sian?
Yeah, that's correct. We've got most people back now.
Okay. Do you have a system for feedback?
I think you were just going to call upon the facilitators from the groups to see what 4 bullet points that they would like to share with the group.
Well, I'll kick us off. We had a small group, mainly of clinicians, but also public advisors and some academics. Most of the clinicians actually wear 2 hats. They're clinicians and academics, and that was one of the points we make, that those internships and fellowships that enable clinicians to be active in research really does champion research activity and enabling more people to take part in research across the whole spectrum of different people within an organization, not just doctors, but a whole range of health professionals, but the managers as well and the support staff. They all have their role to play, as well as our public advisors. And the other big thing that was said in terms of barriers was time, money, interest and enthusiasm, and how the ARC can help to overcome some of those barriers. Now, anybody else? Paula, do you want to speak?
Yeah, well, I was just started putting it in the chat because I'm conscious that there's loads of people who might want to feedback. So one of the things we talked about and we put in the chat was something about the local impact and how that translates upwards into the national narrative. And that fed into a conversation that Megan was describing on a project she was involved in about real impact locally with, you know, quite a lot of co-design, lots of wider stakeholders going to a round table in London and then to a grand fanfare and then it falling somewhere down because it wasn't taken up. So how do we ensure, and we did talk or touch on some of the examples, but how do we ensure that there's a policy sort of lens applied to some of our impact that we would want to take further. Yeah. And then we also talked about the local into the national, because as a collaboration, we're quite well connected to local government. So what does that mean? How can we sort of have conversations more locally that can sort of give us some of the solutions that we might want to those national conversations? And then lastly, we talked about language and framing, and that our 30-second lift conversation can sort of mean the same generally, but we might need to nuance it subject to who we're talking about. And then last but not least, the sort of the public input, then when quite often in terms of efficiencies, we talk about pound notes, when sometimes we could think about a broader impact in terms of population health kind of considerations.
Great, thanks very much. Just to were we to be funded for ARC2, then one of the things that ARC2 expects us to do is to share our best evidence for national spread, so that it's expected that the ARCs will collaborate with their projects that are closest to implementation, so that we can do that with each other and for each other. So that, I think, is a real expectation of the funding next round. Thank you very much. Can anybody who else wants to say anything put something in the chat like Paula did, so I can see who's put their hand up, or stick their hand up, or just talk?
So I've put my hand up. So
yeah,
I
can't
say
see
that
them all though.
Change it is something that needs tenacity. We need to speak their language at their meetings. We need to get something snuck into policy. So we need those standard operating procedures if possible. And it is difficult with the financial stresses that are in place, especially with the work that I do that has public health implications that will benefit the next generation more than the acute population of this generation. Journal clubs are really good to expose people to uncertainty and get them to the idea that there's different ways of doing things. We want to get results into practice, so it's not just about the academic papers, it's about the dementia game, it's about Groundswell have got this data detectives game that will show young people how to join up environment and health data. I think that was it.
Great,
to say that the ARC was really needed because we're doing good work about trying to change these things.
Okay, so I've got Jenny's put something in the chat.
I've got Mark.
And you've
Alison.
got your, I was coming to that. So Jenny and Alison. So Alison, if you want to come in.
Okay, hurdles to implementing research findings. We talked a lot about that. So the evidence might not be available. The context is really important. We need to know our own region, the challenges and the barriers. Overcoming some of the mindsets of people, time, resources, skills, actually have staff having the time to and the skills to get involved in research and discussing research findings. And the language might be a barrier the language that we use in research might be a barrier to getting people involved. Also, quick wins don't actually solve everything. Which approaches that the ARC's done well? We thought that the public advisor involvement, stakeholder engagement, focus on health inequalities issues, and the joined up working and the smart working that we do. And on the third question, what could we do to help ensure research makes a real difference for users of services? We thought that there's a great need for creative and innovative communication and communication that's targeted towards different audiences there. And we need to get information from and to people that have been involved in the research. And also newsletters were thought to be quite helpful. I think that's it, but I've probably missed loads. Thanks.
Okay. Leila, Valerio, and then Jenny, if you're there, and then I think we need to move on.
So from my group, I guess the main things we spoke about was number one, the need for co-production right from the start. So why the research is taking place, what is it you want to find out, who is this going to benefit, and maybe also help to demystify the research process a little bit, like how does it work? We spoke about communication, so adapting your language. People have different styles of learning, different ways of taking on the information. So adapt your communication. Ensure that you have outputs that are helpful for the people that you are working for and with. It can be tempting, I guess, for people to kind of have a little bit of a pet project, which might not be, if you go back to the co-production and helping to come up with the research question, again, it might not be necessarily helping the people you're wanting to help. There were some good examples of screening projects, more related to Clark, but successful kind of increased uptake of screening products that was given as an example. And I think that was it.
Okay, thanks. So just anything anybody wants to say, Valerio, Jenny, there's quite a few in the chat that hasn't been said before. So Valerio?
Oh, thank you, Mark. Yeah, in our group, we just discussed the difficulty of converting research outputs into outcomes and how to find a way in, or building on a way in with the system, involving people, maybe leaders or as social care professionals since the onset of research projects. This could establish a two-way feeding system where we align to their needs, and also they are able to have their say into the research products and its delivery. We also talk about the difficulty of involving staff. We do a great job in the ARC in terms of involving public members of the public, but maybe involving staff is something we need to work a bit better on. And
yeah,
that's it. Thank you.
Thank you very much. Jenny, did you want to say anything?
Yeah, just a couple of things. I've put most things in the chat, but we did have another couple of things, like buy-in from stakeholders is a barrier because people don't always have time. That's kind of been mentioned. How we document implementation is a barrier as well, because people need to know how things have been implemented, and that's not always published. But I think some of the things that came up have been mentioned, but some of the things that we talked about were also the fact the length of time that it takes us to do the research is not always, it doesn't always align with our members, because their practices are changing all the time. By the time we've got things to implement, they may have already done that or moved on from that. So it's trying to keep our research work relevant. So how do we do that best? And we talked about the need to work very closely with our member organisations and really build those teams that are there from the start to the end. Otherwise, we don't have that insight into, the actual practices and the changes that are happening on the ground. And we need that insight to make our work relevant. And when we talked about examples of what has worked well, COVID came up as a really good example. And I think that's because it's a one-off, unique time when everybody basically down tools and we were allowed to focus on one critical priority area. So that was a really interesting one. I think that people thought that really worked well because we were working with stakeholders addressing a major problem in real time as well. So I think it's about taking some of the lessons learned from that, about how we can move forward and work like that again with our stakeholders. Thanks.
That's great, thanks. I'm aware of time. So one of the things which I think is a bit of a myth is that it takes 15 years to get research into practice widespread across the NHS. I think in COVID it took about 6 weeks to 2 months. So I think it depends on how urgent it is, and maybe some of the things that people wanted to be implemented, the practitioners didn't agree that it was the most essential thing for them to be doing differently. So it is, I think the key messages that are coming, if you look through the chat, and lots of common things are, some of these are slow burns. We're still doing some of the Clark work we did 10 years ago is still very relevant and still important. It's not that it's slow to put into practice. It's still, it takes time to spread widely to everywhere, but there's still interesting information. It's about involving the right people from the right time, from the beginning, but also setting up the organizations and how we can work with our members and our partners, if we get out to make sure that the right people know about what we're doing and how to get involved, and that the organization buys in to supporting change and supporting that investment. So great ideas. Haven't really got time to go through them all. Lots of information in the chat. 5-minute comfort break, and then we will come back, please, to the next session, which will be some impact case studies, and we'll be hearing from Valerio. Can you all come back in 5 minutes, please? And we'll have caught up most of our time. Okay, welcome back, everybody. Let me just see how many we've got 82 back in, so whether they're all actually here, don't know, but let's get going. So Valerio is one of our colleagues working in the University of Lancashire. That's another announcement to make for those of you that aren't aware. University of Central Lancashire is now known as University of Lancashire, and Valerio is a research fellow there. So he's going to talk about our rapid conversions of economic evaluations. You heard about the races earlier. This is a races. Valerio.
Oh, thank you, Mark. Like Mark was saying, I'm going to give you a quick introduction into the RACEs, rapid conversion of economic evaluation, and I will talk also about the impacts of the RACEs course so far. So the RACEs course is a course which provides people with the skills to learn more about health economics and health economic evaluations. We have a similar approach to the RACEs, so we're a bit of a younger siblings to the RACEs, but we apply that approach to economic evaluations. We do an online course with 6 sections, followed by a face-to-face workshop, and the first course started in May 2024. We had 3 courses so far and about 35 participants. So far, we are producing 12 commentaries with 2 commentaries now set for publication. So these are commentaries which we co-produce with the participants, and we try to critically appraise an existing economic evaluation paper and try to formulate implications for health or social care policy and practice. If you're interested in the next course, you got the QR code for the registration form there, but I'm gonna pop the links also in the chat in a couple of minutes. Now, talking about the RACEs impact, as I was saying, we only started the course in May last year, so we can only talk about medium-term impacts so far. We had a series of interviews with past participants, and we also ran some interviews last week with our current cohort participants. All the views or the key views from the participants have been included in the standard NHR impact story, but importantly, we also have an impact booklet which Shan masterfully prepared for us, and she included all the key views from the participants, and I'm going to share with you some screenshots about these case studies that Shan put together. Here are a couple of screenshots of case studies from previous participants, and I'm going to also share some quotes from previous participants, from public advisor, people involved in health or social care, or people from local authorities or third sector organizations. All in all, I will say that main impacts from the RACEs course so far are been around demystifying health economics and health economic evaluation. So enabling people to read an economic evaluation paper, understanding the findings, interpreting the findings, and whether they might apply to their everyday activities. There has also been value found by the participant in terms to being confident in discussing economic concepts and problems in the discussions they have with, for example, other parties or stakeholders in their health or social care organizations. And I would say, all in all, the RACEs have managed to championing the value of accessible economic literacies across different organizations, and not only for leadership roles, but also for other health or social care roles. Now I'm going to leave you with an interview which we ran with one of our previous participants, Maria Tanesca from the Alzheimer's Society UK, and you also got the QR code to the full RACEs impact playlist, which you can find on YouTube. And I think, Shan, you're now playing the videos for us on YouTube for Maria's interview.
Yeah, of course. I'll just play that in now.
Thank you.
Work as a service developer at Alzheimer's Society UK. And during the course, I worked, I was in the dementia group, and we worked on a commentary of a study. Let me just think what the study was about. It was a health economics assessment of a digitalized remote cognitive assessment tool for early identification of dementia. So they were assessing whether it is more cost effective than the standard memory assessment offered at primary and secondary care on the NHS. So when I applied for the course, I used evidence more in my role. I was a research evidence officer, and my role was to use and summarize evidence in a digestible way to help decision making or service development. Now I'm a service developer, so I'm a bit further down in how I use evidence. So now I use evidence so I can develop new services. And why I wanted to understand health economics is just so I can make better decisions in my role. Basically, it was really important for me to understand the economic implications of the evidence I'm using and the interventions that I'm reading about, and interpret those cost effectiveness, basically, information. Particularly working for a charity, it is really important for us that we make the most of our volunteer income, and that we make the biggest impact for the people we're supporting. So knowing and using this information is quite useful when making decisions. Yeah, I think I really liked the course. I liked that we were divided in thematic groups. So mine was focused on dementia, and it was very relevant to what I did. And it was a small group, so it was quite practical. The course was exactly what I expected. So I didn't want to know how to run a full economic evaluation, because I don't need that, and this is why we have health economists. But it was for me to know how to use this information, and this is what the course equipped me with exactly. Yeah, of course, as I mentioned, it's just really critically appraising and understanding those the health economic evaluations. I had some basic understanding, but bringing the concepts such as like the which sources of costs are used in the specific evaluation, or what perspective was used, was important for me to understand the implication, basically, of what I'm reading. Yeah, I think they were really happy about it when I shared it, and they had no remarks with basically what I've put. And I think it was quite relevant, because as an organizational priority, diagnosis, especially early diagnosis, is quite an important organizational priority for us. And exploring digitalization, I think it's quite relevant. So the topic was quite relevant, and I think it might have even more impact going forward. Yeah, I mean, I think the course is good because, as I said, it makes health economics accessible to anyone. And in my opinion, you don't need to be at a high executive level to make healthcare decisions. I think everyone involved in health and social care makes decisions about the care we provide to people. And ideally, we would like people to have access to the best available care, but unfortunately we are restricted by finances most of the time. And I think even if you're like a group coordinator and you're deciding what to use for your group, having access to that to information about health, understanding the cost implications of your decision, I think would make it much more effective. So I think it it is worth taking that one hour every few weeks to develop that skill, because I think it is quite useful, and it's not something that you would usually do. I think we think of health economics as something that's for other people, not for us, but I think it is for everyone, especially if you're working in the health and social care space.
Okay, thanks very much. Sorry, Valerio, you carry on.
No, that was it. No, thank you, Mark. Thank you, Sean, for playing the video. Thanks.
Thank you.
Okay, so after that, we're going to go back into our group rooms again. We've caught up time, so brilliant. Thanks very much. I might be forgiven there. Into the breakout rooms, and we're going to talk about case studies and what ideas for case studies we've missed. Some ideas are put on here: public involvement, service delivery change, and specifically looking at those in the areas of hospital to community, analog to digital, and sickness to prevention, which links with the talk we had at the beginning of the morning from Naheed, as these are the key areas for NHS change over the next decade. So into our breakout rooms, and we will meet again at 15:15. Through long lists of case studies that people came up with as the feedback, I suggest we could put them in the chat. I'll just, while people come back in the room, I'll just make a couple of comments. The reason these case studies are really important are because it helps us overcome some of those barriers to implementation we were talking about before, because it allows that communication to be made with our member organisations and other ARCs about the work that we're doing and that they may want to pick up and run with and implement. So we make an impact by telling people what we're doing, and often writing a case study is a really good way of, in a couple of 200 to 300 words, clarifying what we've done and how we do it. Darren will tell you, come and answer your question in a minute, Paul, or I'll pull him in to answer that question about how he can support. And the other reason that case studies are really important is because it's part of the expectation from our funder, the NIHR and the Department of Health and Social Care, because there's a man from the ministry, the Treasury, that comes into NIHR each month and says, show me your case studies. What are we getting for our investment? And so NIHR is expected to show, and therefore so are we, because we're contracted to NIHR, to feed through those case studies to show what that public investment is doing and how it has the potential to make a difference to the quality of care, access to care, and moving forwards on the 10-year plan in the NHS and improving the quality of care and the access to care in social care, etc. Darren, do you want to answer that question about how people can get support for case studies?
Yeah, so anybody who's got an idea for a case study, especially after this event, please email. We'll take the ideas away in the chat and follow each one up. I will send you a template from the NIHR, which is what they use to capture a case study in a format called an added value example. And that means for our annual reporting, we have your example captured and we can consider that as part of our reporting. However, stage 2 to that is I take that completed form and make a case study in the example format that I've put in the chat today, such as that races example. And the reason we do that is we take 2 key stakeholders: one, the NIHR in London within the format they asked for, and secondly, in a publicly accessible format. So for example, if a public advisor was in a meeting in a trust and they said, oh, we've worked on this subject before, they can provide a link or a URL to the case study, which is more accessible and user-friendly. We will also have links within the case studies to the findings and publications, but not everybody is comfortable with going direct to a publication, and some members of the public feel, well, this is quite highbrow, etc. So we've got to consider all of those audiences, and that's the 2-stage process that we do.
I think I'll just skip through a few of the ones that are in the chat. It's quicker than asking people. So there are a number of them there. The ones we had were on bowel cancer screening, one for the future on big data. So, and that will bring together a couple of ARCs at least. And then Public Advisor was talking about how, and I think that links with what Paul has put there about our processes, highlighting the work we've done to enable those who called seldom heard to listen to, and how we get listened to groups from those who've not normally been reached out to, and putting some case studies about how they've been involved, how things have changed as a result of their involvement, both for them as well as the work that we're doing. There'll be other examples of the work that we do and how it makes a difference. There's lots of things in there, too many for me to go through. Please do look at the messages from 12/18 onwards, which are the feedback from the groups, rather than me going through them one at a time. I don't think we really have time for that. Complex households tool, some of the ones we've heard about already today. Citizens' advice on prescription was something they've done in public health, and all of these will be worked up. The more we can do, the higher profile we will have, the more influence we can make. Andy, I can see your hands up. Stops me wittering on.
Yeah, I just wanted to mention one suggestion, which I think lots of people would like, which is to have some case studies of the wider impacts of being a public advisor, because there are wider impacts on understanding of health, understanding of systems, wider impacts on families, wider impacts on communities. And I don't think we've got that scope in our current understanding of the benefits of being a public advisor. I think that would be a great thing for us to pick up.
Well, we are actually doing, Selina may want to talk briefly about this, but there's an active evaluation going on of how people have been involved, how they've been able to influence or not, and what difference they've made. Is that right, Selina? I think we are actively collecting that at the moment.
Yeah, as part of our social network analysis that we've been doing, we've also been doing qualitative interviews with advisors about their sort of journey of being an advisor and how it's affected them and where it's taken them and stuff, and how they've been able to influence projects, but also wider out into communities and organisations. So hopefully some of that will be picked up there, Andy, but definitely a really important point. Thanks.
Yeah, I think it's great.
Okay, right. Thank you very much, everyone. I think that sounds like a time for another quick rest break, and then we'll come back on bang on time. We come back in 5 minutes, please, and then we've got 3 more presentations, and then a final open discussion. See you all in 5 minutes. And now see him from infinity to beyond, or whatever it is.
Yeah, so this is our title. So I'm Katy, Cleece. I'm a social work research lead for Lancashire South Cumbria Foundation Trust. I'm also a community settings lead for the RRDN and currently an NIHR pre-doctoral fellow as of last week. Clarissa, I think, is trying to get in, so she might join or she might not. If she doesn't, I'll just talk through.
I'm here.
Oh, hi. So yeah, I can't see anyone, but I'll give you a nod when it's your bit, Clarissa. So yeah, this is our social care research from communities to beyond. So in the beginning, sticking with the theme, I did a social work practitioner research programme that was funded by our NHS Trust, and that was over 6 months with a social work professor and a social work academic, both working at UCLan. And they took us through 6 months of small scale research, kind of methods, approaches, design. And within that time, we created our own small scale evaluative projects. And that was my kind of toe into research research, really, because we know social work research is quite far behind other professions. There's lots of barriers and where people don't take part in practitioner research, and it only really tends to happen with social work academics in university. So from doing that first bit, an NIHR fellowship grant was secured for social care capacity building, and that was used to create a research lead within our trust for social workers. And most of that role really was about getting people excited about research, getting social workers excited and connected with research, and building capacity to do research. 2 years ago, we got some funding from NHS England for their research engagement network programmes. And the first thing to do was kind of think about how we were going to increase those seldom listened to voices in that research space, and kind of, I suppose, more nationally with NHS England when priority setting is done, research grants are designed. So previously, before I was a social worker, I worked for a drug and alcohol charity called Early Break and managed a service called Holding Families that was for parents at different stages of safeguarding and different stages of recovery around drug and alcohol use. So I went back into there as a charity and said, right, we've got some money, we've got some ideas, because we know as a group of people, you are not being heard. So there's lots of research that goes on around families and how things are working or not. There's research around drug use, but there's not a lot being done with parents around drug and alcohol use. And there's lots of reasons why those voices are not heard, where there's a lot of stigma around that for people. So we went in and said, look, we've done this practitioner research programme. We know some ways of upskilling people in research, but we don't really know what you as a community might want. So we sat together and really kind of co-designed this programme of how this would be best delivered to communities, and looking as well about what people's barriers were and what was important to them, so that could be fed back to NHS England. And these, obviously Chris is on the call, I'm on the call. These were the group that we engaged with, Professor Aidan, some of you will know at the back. So we went into this group and this is how we worked. And we did some fun stuff, as you can see on the right. This is what's right on my screen, I think it's on yours. This was part of a comedy coaching session we did to bring us all together and increase confidence. And on the left was everyone's certificates at the end, because that was something people wanted to show the work that they'd done. Nothing's working now. I don't know why this is not moving. Oh, there we are. So Clarissa, do you want to just talk through the model that we created and some of the outputs?
Yeah, so from our session, we created a poster, and it was really good because my friend who I'd done community rehab with, she's an artist, so she designed the poster. So we still kept it was like other people coming into the group with the same sort of issues that I had, but then they all had an opportunity to get into research somehow. So then I was trained with other social workers to deliver the other REN programmes. So I worked with homeless in Blackpool and parents with children with challenging behaviour in Blackpool as well. And then I'm going to be doing some more projects in Burnley. And when we did it, we had supervision with Katy, which I really benefited from. However, because the comedy workshops went so well, we tried that and they really made a difference. So I remember when we were in Blackpool, the younger people that we worked with, they went to the same centre every day, but they just didn't really communicate with each other. And after the comedy sessions, they all became friends and they were all there for each other. And then when it came to do the research, they were a lot more open to talking, and it brought the guards down a lot. So that's why comedy is now in with the REN projects. We also did Me and by Mortal's audio piece. So that was all of our stories, and they were brilliant, the team there. So we all talked about what had gone on in our lives, and then they wrote a script, and then we designed the music, and then we went to a recording studio and recorded it. And that when people have listened to it, they said that they've got more empathy for people in recovery of addiction, and the stigma's reduced a lot. So that's a really powerful piece. Then we went to uni and did the races. So we did, and then we did a poster for that. So it was about how mothers and children can be helped in services. And we did an umbrella, what will help and what will not help. Then me and my friends, so again, when I did the recording for Made by Mortals, my friend Victoria, who's in recovery, she just came to do the recording, but then she's had something quite terrible happen in her life through addiction. And she really wanted to make a change in the system. So I said, oh, well, why don't you come and apply for this internship with me and do some research? Because I went to rehab, community rehab, and I found it really difficult as a mother. And I just thought it was a lot easier for men, and I just didn't understand why there's not like as many services for women, like women only rehabs. So that's like what I'm going to do my research in. So yeah, so we've both gone to that. And then now we've got the job as peer researchers. So like I said, I've been facilitating the REN groups, and then I've been going to conferences, social research conferences, and talking about my experience. And then we've co-produced the next lot of REN. So the presentations were completely co-produced by not just social workers, by people with lived experience. Oh, and I work with the Deaf Village as well. So I even forget, I just do that many things since I started. It's unreal. And then we helped to design the toolkit so that anybody who wants to carry on the work we are doing, it's a really good toolkit, and it really helped me to work with the communities by reading it and adding to it. And that's it.
Thanks. And we've just put the link on the bottom, haven't we, to the Made by Mortals. So if these slides come out, people can hear that audio story as well, and it should be on their website. And that was funded through the ARC as well, I think. Just work out this. So this is the poster that Clarissa was talking about. Do you want to just mention, Clarissa, the different bits that are on it, and then I'll do the next one?
Yeah. So as a group, so everything in the REN programme was just really co-designed. So we all sat down into two groups, and we both came up with our ideas of what we wanted the poster to look like, and this is what we came up with. So we were thinking about how families sometimes, when they're going through troubles, if they don't receive the right help, they can just be a sinking ship. But then if they get the right help, like that's the balloon. So this is how and who should do it, because people sometimes they're not honest with people because they're frightened of being judged. And if you've already got that attitude of judgment, then you're not really going to be able to open up. And I think people forget what social workers are for. They're there to help you, but because everyone's so frightened of saying anything and the children being removed, or this will happen to me, that'll happen to me, then they can't access the help. So this is why. And then in recovery, we say you work it, you're worth it at the end of meetings. So that's where the title came from. So yeah.
Thanks. So the races that we mentioned before, and I think a lot of you'll know about this anyway because it's connected to ARC. So there's Dr. Catalin, who we worked with, and there was a group of, so I was involved, but also a group of people with lived experience of substance use who were parents. So we looked at specifically maternal mental health and what the impact is of children's social care with mothers with mental health difficulties, and then came up with this commentary piece about actually what would be helpful for people and how this can be better used in practice, and how sort of social workers in the children's arena can work better with mental health services and families. So this is the RACES programme. It's led by the MIDES team. And yeah, like I said, we were quite a mixed group. So we've got Kathleen, who's very experienced in research and knowledge synthesis, and then myself, who's less so as a social worker, and then obviously the group as well that hadn't really done anything like this before. So together we came up with what to look at and decided not just to look at substance use, but specifically maternal mental health, given that that was very much a feature for everyone in the group as well. And we had a day at UCLan where we did this follow-up and some of the writing of that. And I think the important thing to note is that every time we went in and worked with a group, they were paid for the time as well, just to reduce some of those barriers, I guess, between paid staff and unpaid staff, and make it that we were on a more of an equal footing. And we did have outputs. So we had an article published, and I think the link's on the next page. There's also a blog in research and practice. So that's something that every single local authority and lots of NHS trusts where we have social workers sign up to. And there's practice pieces within there. So rather than reading a journal publication that, you know, might be behind a paywall, we might not have access to it because we're not connected to university, research and practice is out there, and it's usually between 1 and 3 pages long. It's very much a practice policy briefing. So it's the sort of thing that social workers who are busy in practice would have time to read and look at. And as Clarissa said before, we've been to quite a few, so like presenting at things like this, but also kind of conferences up and down the country, one of which being research and practice, so we can really share that work. It's not just done and sat on the shelf for no one to look at. Okay, so this was, as Clarissa mentioned, this was the visual output that we came up with. So talking about lots of the barriers, and you can see them there, things like anxiety, stigma, trauma, neglect, children being removed, mental health problems. And then we, as a group, we kind of said, well, it'd be really good to think about what the umbrellas are to protect against that. And that's where the title came from. How can we strengthen our umbrellas? And underneath there is some of the things that can be really done by services to improve the outcomes for people, but also improve the relationships. So the top link there is a link to the journal article, and the bottom one is a link to the blog and also this infographic. And Clarissa, I'm not sure if Victoria's on as well. They're just going to mention a little bit about themselves as peer researchers here.
Yes, I'm here. Can you hear me?
Yeah, do you want to just mention your bit, Vic, please?
Yeah, if you want. Want me to talk now?
Yeah, just tell them a bit about yourself and your story.
As Clarissa said, I came in right at the end of the Wren project, where they recorded the Made by Mortals audio immersive project. And I really enjoyed that, and I thought, wow, I want to get involved in this, because I've got very extensive lived experience of having my child removed and what went on and everything. So it really resonated with me, because that was what it was all about. So I applied for the internship, like Clarissa said, and it's been brilliant, and it's really validated me as a person, in my opinion, because I just thought I was just some sort of, loser, failure. I'd had my child removed, and why would anybody give me a job? And now I've got one, and it's just been absolutely brilliant. And I feel like I'm going to make a difference with my research of how certain people in social services treat people in that situation, and hopefully make a difference. So yeah, it's been brilliant.
Thanks, Vic. Clarissa, was there anything apart from what you've already said about your role that you wanted to add here?
Just when we talk about co-production and people sort of just use it as a tick box exercise, but like, this is what will happen if you actually use it. So people probably wouldn't afford to put me in as something like that. Even I, like Vicky said, it really like helps with validation, and I'm considering becoming a social worker now. Like, so this this is all just like from these little things. So if you do involve communities, and if you do involve people that you wouldn't usually think, you can come out with like things that you wouldn't even imagine, if that makes sense, rather than just, sometimes it's scary to go for things that you don't know, but like the work that comes out of it is something that you wouldn't be able to do if you just followed the normal tick box exercises. And that's it. Thank you.
Thanks. And I think that's the end. I don't know if we've got time for questions or not, but I've stuck my email on there. I'm on LinkedIn as well, so do feel free to reach out at any point. Like I said, I don't know if we've got time today or not, and I'll stop sharing. And big shout out to Sean for teaching me how to share that screen. It seems to have worked.
Thanks, that's great. That's lovely to hear. Can I just remind you that were we to get ARC2 funded, there's a social care theme within that, led by Dr. Giebel, and we would be very keen on getting your involvement, because that will cover the wider ages as we develop that. And if you're not already involved in the social care work that we're supporting, the capacity building work, then Caroline Watkins, Danielle Christian and James Coleman Watson can help you get engaged with that work and show you what we're doing. We've got community of practice who are building a group of people who work in social care to get involved in this sort of work. We've been doing that for some time. So fantastic to hear about that. And it's good to hear about the sort of work that we don't normally hear about. And great power to you, Clarissa and Victoria, for the work that you've been doing and your colleagues. And you make a huge difference by the work that you do. So thank you for that. Okay, if that's okay, looking at time, I'm managing that okay so far. Caroline Watkins from University of Lancashire is now going to talk to us about how we scale up implementation within ARC Northwest Coast. Caroline.
Okay.
You can see your screen, but not as a presentation yet.
No. Hopefully that's okay now.
Yes, it is. Security alert's gone.
Yeah, I don't know what that was about. Yeah, so yes, I wanted to talk to you about our plans, I suppose, for getting impact through implementation, should we get the the ARC2. But I think to some extent there are things still coming through from ARC1 which have a huge opportunity to get impact. And even though we haven't formally adopted the knowledge to action framework in ARC1, and we're planning to in ARC2, I think you can probably see that most of the time that's the way we work anyway. So these are some of the themes, well, the themes from the proposal that we put in. So lots of things, one of which is about long-term conditions. And I wanted to give you an example of something that we've been working on for some time within the ARC, that hopefully will have an impact going forward, but using the framework that we're suggesting we would use going forward. So the knowledge to action framework, which is depicted here, is something that we said we would do. So what we would do with every topic that came forward as an idea for programmatic work, we would look at the explicit knowledge, is what we do with everything already. So we do races and reviews to see what's been done already, from learn from things from the past. And then we see how we can move that forward by talking to people, key stakeholders, patients and the public, but staff and from all different organisations and higher level people that are involved in strategic directions. And depending on what it is, depends on who gets involved. And to some extent then, what we generally do is we have a plan which involves some work packages. So we would start off with a partner and public priority, then we would work through something which we've divided up into work packages so that it's all manageable, we can plan it, everybody can be clear about what's going on. And like I said before, we start off by reviewing what we know already. And then we think about how it can be adapted to where we are and how it can work there. Understanding barriers and facilitators so we can tailor it, adapt it to the local context, and then see how it affects outcomes and what we need to do differently. And then, to some extent, if we do those things locally or in a confined number of centres, then we get to a point where we have to make some decisions about whether something is able to be scaled up and rolled out. So this is using an assessment tool, which I'll talk to you about later. So forgive me for using a stroke example, but somebody else was going to do the second half of this talk, but unfortunately they couldn't do it at the last minute. So I thought I'd use something which is close to home, which potentially could have a huge impact going forward. So when people have a stroke, there's lots of psychological problems that can occur, and depression being a key one of them. These psychological problems interfere with people getting better. They interfere with them participating in rehabilitation. It interferes with their life in the community, and it has a big impact on everyone around them. So it's something that we should really think about doing something about. We know from past research, so when we looked at the literature, there's been a review that looked at, you know, how many people at any time point after a stroke have depression, and it seems that at least a third are clinically depressed at any time point after their stroke, and as well as people who are clinically depressed, there are people who have a great burden of depressive symptoms, which, you know, we should try and do something about. So we have guidelines that give us an idea about the things that we think we should be doing, although some of these are not necessarily evidence-based, but they're expert opinion. There have been systematic reviews that have been done to look at treatment of depression. So drug treatments, so the antidepressants have been shown to reduce scores on depression scales. But the problem with drugs often is that they also have nasty side effects, which reduce people's quality of life. And so you have to balance taking them with how they affect your life in other directions. There's also some evidence for psychotherapy, so talk-based therapies, except a lot of the studies that have been done have been a bit too small, not very well designed, and so the evidence for these things isn't great. So why wait till people get depression before doing something about it? Shouldn't we try to prevent them getting depression? If we know so many people get depressive symptoms or clinical depression after a stroke, why not try and nip it in the bud? So there have been some prevention trials, again, looking at what's been done before. So drug treatments, but that wasn't really particularly helpful. But talk-based therapies did seem to have some kind of beneficial effect. And one of the studies that was contributed to the evidence was a study that we had done on motivational interviewing after stroke. Now, this is a talk-based therapy that in this study was done face-to-face, either in hospital if people were still in hospital, or at home if they'd gone home. There was 4 sessions, and it showed in this study of about 400 and odd people at a single centre that there was a significant reduction in the proportion of people who were depressed at 3 and 12 months. And in actual fact, less people in the intervention group had died by 12 months. And so it's an important intervention that not only improves the quality of life of people, but also treating 12 people can save 1 person from dying. So if you could roll this out, scale it up in other centres as well, we'd need to see whether the effect of this 1 centre study would be maintained. So the main approach here is about talking to people, finding out what their concerns were, exploring the concerns, thinking about how people had approached dealing with problems in the past and how they'd overcome those things, to help them to see that actually, even though some of the things were fairly scary, in actual fact they had their own, through their own resources, overcome a lot of problems. And this is about trying to increase confidence in being able to return to life after stroke and to feel more optimistic about the future. So all very well if people can have a conversation, but obviously a lot of people who've had a stroke do struggle with having more detailed conversations. So in order to take this forward, we wanted to increase the people that could access this, and we did some exploring of how we could facilitate these kind of talk-based therapies with people with speech and language problems. So it's about using aids and adaptations, so we could include people with aphasia. And then this has led on to the COMMITS trial, which is now the definitive study that has been supported by the ARC and also by NIHR wider funding. We've had 18 sites participating, and this is all the patients that have been recruited at each site over the past few years to the end of July this year. We've just got recruitment now to the end of September, and then we should stop recruiting then, because we will have the 1,200 patients that we needed for this study. And we've had to be fairly flexible, and I think this comes to trying to find out how we can implement things in practice, because different sites have had different challenges. So the intention was to train up staff within the sites to deliver the motivational interviewing intervention. However, some sites didn't feel that, although they wanted to participate in research and wanted to give their patients the opportunity to participate, couldn't identify staff that were able to be trained in the talk-based therapies. And so we agreed that for some sites we would allow central provision of services, and that is happening in other places. Now we're able to do things remotely, so this is sort of analog to digital, I guess, in a way. So a lot of the sessions have been provided not face-to-face as they were in the first study, but either over the phone or on Teams. So that means that you can have people delivering talk-based therapies to people in Cornwall when the therapist in actual fact is based in Preston. So we've had a mixed model of delivery in terms of whether it's centrally supported in terms of delivery of the intervention or at the sites. Sometimes the sites started with getting their staff trained up, but then people go on maternity leave or long-term sick, and it's difficult to train people up quickly to replace people. So then we would have central staff that stood in. We also got some funding for Stroke Association staff to deliver this intervention at some sites. So they have been able to do that as well in some circumstances. So this trial then will give us information about not only about whether this intervention works or not when you try and roll it out, but if different types of people, whether they're OTs or physios at sites, or whether they're stroke family support workers, or whether somebody centrally is providing the intervention itself. So 13,000 people have been screened, about a third were eligible, about a quarter were consented, and 1,181 have been randomised so far. So we're aiming for 1,200. So like I say, we should finish recruitment by the end of September and then do the 3-month follow-up by the end of December, early January, and therefore we should have the results hopefully before the end of ARC1. So then we need to think about how we take that forward. If it is something that should be rolled out, or something that should be stopped, because some sites have stopped recruiting, but they've carried on providing motivational interviewing because the staff delivering it and the services felt that they were being beneficial to people. So we have to think about whether we should be, yes, continuing on or stopping people doing it, or how it can be rolled out more widely. So if we use the intervention scalability assessment tool, which is what we've suggested that we would use, this has 3 dimensions of exploration of the results, and to look in detail about, what the problem is, what the evidence is for the effectiveness of the intervention, what are the costs involved in terms of what it costs and what it saves, and then There's also about how it needs to be adapted, what are the implications for the workforce, and so how can it be implemented, and is it sustainable? And these things are then sort of summarised, and a way of visually getting across the intervention scalability assessment is to plot it on some sort of spider diagram, so you can see where things are strong and where things are weaker, and then you can think about, is the evidence for doing this a good thing, or are there some challenges that there would be in implementing it more widely? And to some extent, this is the approach that we're suggesting that we would use going forward in ARC2, should we obviously be funded. So yeah, that was just to show you how it might work.
Great, thank you very much. Lots of information there about how things will be working in ARC2 when we hear that that's been funded. Thank you very much for that. So our final talk today is from Selina Wallis, who's going to talk about impact ambassadors delivered by public advisors and how they can act as impact ambassadors for us. So Selina, over to you. Thank you, Caroline.
Fantastic. Thanks, Mark. Ruth's just going to pull up the slides for me. Just while she's doing that, I just wanted to say thanks to everyone for still being here, for holding us to the end. I think it's been a fantastic session. I just want to say how moved I was by the talk by Katy and Victoria and Clarissa. Just amazing to see the effect that involvement can have on people's journeys. And that's really what I'm talking about today. If we could move to the next slide, the first slide with the map on, please, Ruth. So we've got about, I'm the public involvement manager, in case you weren't here earlier, from ARC, and we've got around 100, it's a bit of a movable number, of public advisors that are registered with ARC Northwest Coast. And many of those have worked with ARC right through its beginnings from Clark, and others are new and have been recruited by lots of different methods, either by researchers or specifically from seldom heard communities via our Seldom Heard Forum. So we felt that we knew from talking to our public advisors that they had very rich connections to all sorts of different communities and organisations outside of ARC. So we thought it'd be really important to map what those connections look like, because researchers are not always aware. So we decided to use social network analysis, and the diagram that you can see is that map. So this is 28 of those 100 public advisors. And with ARC Northwest Coast in the middle, you can see all the little dots. Those are the different organisations that they're attached to. Over 90 organisations from those public advisors. And we found that the network is really rich in charity sector ties, but also all sorts of other organisations around, both in the Northwest, but also nationally and also internationally, with some of our advisors actually running their own charities. And that added up to more than 700 years worth of lived and professional experience combined. So why does that matter? This is a ready route for implementation and adoption, but it's also a duty of care question, because if we ask people to carry messages from our research back into communities, we must equip them and support them to do that. Right, next slide, please, Ruth. So as well as the physical social network analysis, and we'll be sharing more about that on other dates. We also skilled up our public advisor co-leads to interview other public advisors about their journeys and about what it meant to them to be a public advisor. As you heard today from some of the work that's being done across the ARC, it can have really massive implications for people across, their lives and their communities. So we wanted to capture that in more depth their journeys of how did they become a public advisor, why, what's happened since, what are their contributions, their motivations, and their reflections on that journey. So this serves as a core qualitative companion to our social network analysis diagram, showcasing the human stories, systems thinking, and critical relationships behind ARC's public involvement infrastructure. So the social network analysis journey mapping has surfaced not only who is connected in ARC, but how, why, and with what impact. And it reveals a relationship architecture of care, persistence, frustration, hope, and strategies. And these stories deserve to be at the centre of how ARC evolves, learns, and celebrates public involvement going forward. We haven't really got time to go through many of the themes, but I'll just really briefly touch on them, on some of the themes that have come out of these qualitative journeys we've got so far. So we know that public advisors join for all sorts of reasons, join ARC, informal invitations, personal connections, or other lived experience opportunities. Several referenced Ruth Young, Mind, Health Watch, or the COVID diaries as key entry points. Public advisors bring rich and varied experience across health, housing, social care, as we've heard, parent carer journeys, refugee and asylum advocacy, chronic illness, mental health recovery, and other professional roles and community leadership. Contributors are involved far beyond the traditional advisory remit, influencing national health data governance, NHS strategy, social care scrutiny, AI, and other university programme designs. ARC Northwest Coast has been praised in many of these journeys for its consistency, inclusivity, training, trust, relationships, and being one of the few places where people feel truly listened to. And I'm really proud to say that. It's created a sense of belonging and purpose for many public advisors. Of course, there's challenges and critiques that have come out, and we'll talk more about that in other sessions on other days. But what we really want to think about now for the end of ARC is legacy and how public advisors are driven by their values. They really want to give back and honour others or create change from painful lived experiences. Several have talked about rebuilding their lives through this work of public involvement. So if we can go to the next slide, please, Ruth. So what can we learn from this? People keep projects alive after that paper is published. Informal networks sustain implementation long after research ends and we move on to new projects. ARCs can design dissemination pathways through people, not just through their papers. And if communities lead knowledge mobilisation, we can accelerate impact and adoption. So what's next? I think we're on the last slide now, Ruth. We're presenting some of this work at a poster at the HDR conference in October, and we're looking to co-design a toolkit and a workshop to see how this social network analysis type of work can give us pragmatic ways to visualise, evaluate and strengthen public involvement networks across the country and beyond. And the goal is to inform future research strategies and resource allocation. So I just want to close on a message to leave you with today. Our public advisors already hold the relationships that make impact both possible and much further reaching. Communities are not just audiences. They are credible messengers who can translate research and services into everyday language in the places people already trust. If we equip community ambassadors with clear messages, quick routes back to us and fair payment, then impact will last. This is how we move from projects to practice, people first. Thank you.
Right, that's great. Thank you, Selina. So, can we stop sharing the screen, or have I just got to stop doing the way you have done? So I'll just look at how I can get the way I can see all the participants, because at the moment I've got my gallery view is wrong. So
if you go up to view at the top, Mark.
I know I'm looking at it, multi-speaker. Still got that still isn't right.
If you switch it to gallery, it'll switch it back for you.
Yeah. Okay. Got it. Okay, so we've got 80 participants. I can't see everybody. So if you want to contribute, please do. Actually, if I put the participants on as well, and I'll flick up and down that so I can see, should be able to see hands coming up. So please stick your hand up if you wish to speak, or just put something in the chat and I can keep an eye on both as well as the screen. I've got 3 eyes. Any feedback, any questions? We've got I think most of, if not all of our presenters are still here. So now's the chance to ask questions. Any things people have learned, any ideas they want to take away, any things they'd like to get more information about? Now's your chance. Don't all put your hands up at once, otherwise we won't be able to manage to. That was sarcasm, for those that hadn't noticed. Darren, let's start with you just to get the ball rolling. I think there's a number of people who aren't quite clear how we want to run case studies in the ARC and how the ARC can help people write case studies. And the case studies have different audiences. I think it's important to say we've been talking rather selfishly as an ARC about the case studies we need and want as an ARC to be able to share with our members and other ARCs, as well as central government through the NIHR, to showcase the great work we're doing. But of course, those case studies are really important, I'm assuming, for all the different types of organizations that are parts of the ARC. So trusts will want to be able to show their directors and their managers and their boards the work that they're doing. They'll want to publicize that work on their websites and in their newsletters. So those case studies aren't just for us, they're for our member organizations as well as going on social media and our website. So they are multi-purpose and they can be crafted, and Darren can help, and the comms team can help, and we can help craft those messages for different audiences. So do you want to talk a little bit about that, Darren?
Yeah, you've just answered the question really, but that's exactly what we're trying to do. And as we're ramping up our work, coming towards the last, was it 7-8 months of ARC, you know, I think Sarah said before, there's a lot of work that is starting to show, groundswell, some of our projects. So there's a slight catch-up game we're playing in comms in trying to capture all of this. And it will be much more than legacy, because if we can disseminate it to the other organisations who are our members across the collaboration, use, you know, you look at that social network analysis that Selina's just provided, that's our opportunity. That's what we've invested in and built, and what we've got to use and put through the case studies through them. And just to go back to Andy's point as well earlier today, yeah, I sometimes might be guilty of writing case studies and prioritising those for NIHR where I'm thinking of service change. But it's a really valid point of how, you know, the NIHR investment has also changed lives from our public advisor perspective as well. And I think we need to remember that. It's not just about the hunt for frontline service delivery. It's about some of those wider impacts, and that's going to be part of the Clark ARC legacy as well, and why it's so important it's captured.
And I should have said that, thanks for that, Darren. The other audience, of course, is our communities and our public and the local authorities and organisations where those communities and those members of public are, and where they're linked to, because as well as publicity, wider engagement, but some of the ones we've been talking about how to engage different communities and groups, that's very important messages to get out there, as well as to sell our model nationally. I think, well, I know, in fact, that our reputation for public involvement, community involvement is very high, and the plans that we have for how we will do that in ARC2 have also landed very well centrally. So we do have a strong reputation for that, and the model that we have adopted and the approach that we take is essential to be spread. So and the case studies underpin that. Can you hear me? because my electrics have just gone funny. I just need to sort it out.
Yeah,
we can hear you.
yeah. No, we can't. No.
That's because you've muted yourself.
Yeah, sorry, that was you can hear me now though. Right, so looking for more hands, comments. Chance to, okay, Howard, I can see you put your physical hand up. Howard, just introduce yourself, please.
Can you hear me, Mark?
We can hear you, Howard, loud
lovely.
and clear.
Yes, yes. I'm a member of the North West London ARC. I'm not one of yours, but I'm a patient member, patient and carer member of the ARC Management Committee, and have been for a long time. And a lot of us spend time and do valuable things. Can I just make a quick comment, Mark, because I haven't been here most of the morning. I was here for the start, but I put a note in that I had to have a examination at the local hospital, and I forgot completely about it and had to shoot off. Anyway, all I want to say, Mark, is firstly a word of great praise for your ARC, the NWC, because you seem to lead on so many things. You have an excellent newsletter, and I get the point of this morning. It's really a partnership. All I'd like to do is throw into the pot about perhaps more liaison between ARCs. We don't hear or see much of what goes on. The newsletter gives us obviously up-to-date detail often what's going on in each particular ARC and the studies they're doing. And I find it all very valuable that academics and patients and carers and all sorts of people, and of course the voluntary sector, are in this together. The only point I make, I'm going to stop in a second. All I'm saying is, can we find a viable way of us all getting together, perhaps a bit more often? If you hadn't sent this to me, I wouldn't be on this at all. I don't know whether we have things like annual conferences, but I'm talking about, because of the technology aspect, we can get together much more and explain how we work and the studies that we do. So that's it.
That's very gratifying to hear, and thank you very much. Someone from London thinks we're doing well up north. So, you know, the Guardian strapline used to be what Manchester thinks today, the world thinks tomorrow, but that was about 100 years ago. Although we're not Manchester, we're Northwest Coast. But just to answer that, one of the proposals that we have made, which we will want to pursue as and when ARC2 is funded, is that actually there's a national grouping of public advisors, and that there is a national community of practice, to use that jargon phrase, of the different public advisor groups around the ARCs, because there's so much expertise and so many networks. So we did a social network project with, I think it was, if I remember it rightly, 24 public advisors. If I get this right, Selina, about 18 months ago, and we asked those public advisors which organisations they were linked in with, and I think, if I remember rightly from memory, there were 104 formal placements on committees and groups in 94 organisations relevant to our ARC, just between 24 public advisors. So you're absolutely right, Howard, our spread of the influence of public advisors is huge. And what we also need to do is to tap into that so that we can work effectively between the public advisors and the ARCs, and we need to mirror that with the practitioners as well in the organisations that we work with, our partners, they'll be called in ARC2. But we also don't want to duplicate and unnecessarily duplicate where we don't need to. So if Northwest London had a particularly good connection with a particular community who had an interest in work that we were doing, we need to know about that. So we don't build something we don't need to, or that when we do build something locally, we can link them up and buddy them up with an organisation that's further along that pathway, or a group that's further along that pathway. So that'd be part of my take on that, Howard, that I hope that we can build on from that, is that we interconnect better between the different ARC public involvement, community involvement systems, and allow them to share and learn from each other, rather than having to reinvent lots of wheels. I don't think we do that very well at the moment. So that'd be my take on that. Alan, I can see your hand up.
Yeah, I just wanted to say, really, I totally agree with what Howard has been saying there. And if I can give an example, meeting both of us were at yesterday morning about the social care roundtable, where I did a short presentation because I'm trying to encourage them to do a project on the transition from childhood or children's services to adult services, and also the involvement of health care services who don't seem to want to get involved at all. And one of the people there said, oh, I think some, is it Southwest, are also looking at a project like that. So he said, right, well, let's talk to each other instead of doing it separately. Let's do it together. I mean, amongst other things, you're bound to get a much bigger impact if you do that, if if arts work collaboratively rather than separately.
So again, that's going to be as part of the bidding document for ARC2 was to demonstrate how we would more effectively collaborate between ARCs on our programs and projects and share, not just for implementation but also for research. How to do that is difficult, and we spent quite a lot of time. Louise and Caroline have been talking earlier. Caroline in particular, but Louise is also here, about structurally how we make sure that when we do put our energy into shared projects, that they're ready for implementation. That's what Caroline's talk was just about. We don't want to be chasing evidence that isn't ready for implementation and isn't in a fit state and doesn't have the right evidence, or hasn't been developed to a stage where it can be spread at scale as we're asked to do. So that's part of the challenge that our implementation teams will have, is to look at suggested implementations and see if they are suitable for us or whether they need to do more work on them. And then prioritize them, because they have to fit our agreed priorities.
Could I also just say that I thought Caroline's presentation was extremely good, and it reminded me of the Vagus Nerve project that Tony Marsden's has now got approved. Well, in fact, it's actually started, which is, if you like, gone beyond ARC in that the project is so big that there are NHS trusts all over the country that are taking part in this work, and it's been funded, I think, through NIHR, but not through ARCs.
Yeah,
so
you're right. There's quite a few examples of that dotted around our themes, and I'm sure that's true nationally as well, that lots of ARCs are projects that link into ARC, but they spread well beyond ARC. So Sarah's Groundswell, for example, is across three countries in the United Kingdom. Clarissa's got work, the Equidem, that spreads over lots of universities and groups around the country. So there's lots of examples of that, but you're right. ARC is an infrastructure. It's a way that we bring the potential for this co-production, which traditionally hasn't been the way that universities have always worked. So it allows academics to find people to work with and vice versa, the practitioners, the public, to be matched up with the best academics to work with them. Right, I don't want to keep rambling because I'm hoping this is your meeting, not mine. Anyone else? I am trawling up and down looking for hands up, but shout out if I can't see your hand, because I can only see about a third of you. Okay, well, I'm not going to labour the point. If there's nobody else wants to speak.
Mark, I'll just wanted to, I put something in the chat, but I just wanted to say, you know, I think it's been really inspiring. I think it's been a fantastic ARCFEST. I've already fired off a few emails to people that I've heard speak today about, you know, getting together and going further with some of the stuff we've talked about with case studies and things like that. So just think thanks a lot, Mark. It's been really good. And
yeah, thanks. There's lots of positive messages in the chat, so thanks for that. And we will be sending out a feedback form shortly. I know these aren't ideal online, and lots of us prefer to meet face to face, but not everybody can do that for a variety of reasons. But part of the cost cutting or cost efficiencies, let's put it that way, of the NHR is we were asked not except in exceptional circumstances to book outside rooms and outside catering for meetings such as this, because of the cost pressures in the Department of Health and Social Care. So that's one of the main reasons we shifted to online only meetings like this. When and if we get to ARC2, then we will be moving back to more face-to-face and hybrid, but as things are at the moment, that's not possible. One of the challenges is that you could say, well, why don't you use university rooms? Well, they're not available during term time, and our meetings tend to happen in term time. So thank you very much for working with us in this way. I hope you found it informative and useful. I hope it's given you lots of ideas for things that you might want to do with the work that we do, or impacts to tell us about, or implementation that you think, oh, what can we, I've got a group that would really like to do something. Is there something out there already? That's why we have the races and the racees, to identify research ripe for implementation that you've heard about today, as well as the work that we're doing. So thank you for your time and your effort, and thank you to our team for your hard work doing the great, you can tell from what was in the chat, you've done a great job facilitating those rapid groups. Thank you very much for that. We will go through that and we will produce a summary and send it out and circulate it, as well as putting it on our website, etc., so that people can see what we're doing and what we've been discussing today. So thank you very much. Finishing bang on time, which I think people will argue is unusual for me. But that's thanks to all of you as speakers keeping to time, and apologies for the late start. We had a glitch, as you saw. We were rapidly trying to change everybody's names away from Sean Cunningham. Anyone familiar with the Bruce sketch in Monty Python? It wasn't that we wanted to name everybody Sean to make it easier. There was a glitch in the software. Okay, so thank you very much, everybody called Bruce, and we'll see you at the next ARCFEST, which will be in December, when I hope we will be discussing ARC2 and how we move across to ARC2. Thank you very much, everyone, and keep well and keep fighting and keep impacting. Bye.